Good evening, everyone. So now we will talk about hardcore tropical neurology. So I have taken the baton from Dr. Vikas. He'll be showing couple of cases. Couple of cases will be shown by me. I'm Dr. Modi. So uh, the idea of this panel discussion is to probably generate some consensus on how we manage these patients. The common confusion always remain between NCC and tuberculoma. So without wasting much time, I'll straight away start with one of the cases and I will request the audience to participate actively in the discussion so that we can have a final conclusion which is quite productive. I think everybody knows the diagnosis in this case. NCC, raise your hands. Very little, I think. Okay. Tuberculoma, anybody? One or two odd hands because it seems to be quite straightforward and simple case. Do we have a so we have a T2 hyperintense lesion. We can see a scolex and a ring enhancing lesion. I'll come later about this contrast seepage. This is a very interesting phenomena which our radiologists of late are depending too much on. So we'll discuss about it. So this was a straightforward case of NCC. Now this is a colloid vesicular NCC. Here comes the problem. This is another case, short history though of only 2-3 weeks headache followed by one episode of seizure, then recurrence and then again recurrence. And this is the MRI of this patient. You can see flare, you can see contrast T1, you can see T2, again another contrast T1 axial, you can see diffusion. And what's the diagnosis? Abscess? Nobody. Tuberculosis? Many of us. Why? One, because they are multiple ring enhancing lesions, and um, secondly I don't know, so they are multiple ring enhancing lesions, right? So what's the so look at it. There is a seepage of contrast. Look at it. I'll come back to it again after 3 minutes. There is a seepage of contrast. There is one ring enhancing lesion here and another here, which is diffusion restriction bright. Mind you, all these words are very, very important. And then one of this has got a proper thick wall and the other one is the freshly forming or new forming cyst. So the diagnosis in this case is neurocysticercosis. I'll come back to about its various features again. There is no ambiguity about the diagnosis in this case, right? Why so? We will discuss about it again. And but look at the contrast seepage. The T1 which is hypo and T2 which is hyper, and there is diffusion restriction. Why this happens, we'll come back to it again. Then another case. Now what about this? Multiple ring enhancing lesions. NCC anybody? No one. Tuberculoma? Everyone. Right? So this is something which has been now explained immensely in literature. So multiple ring enhancing lesion doesn't take you straight away to tuberculoma. That is the most important take home message. Just don't go by that there are 2 or 3 ring enhancing lesions like in this case also. So it can still be NCC. Why and how, we will discuss about it later. And this also ultimately turned out to be a case of pseudo-tumorous neurocysticercosis, and we have reasons for it to say why is it so. So we are today focusing only on NCC and tuberculoma. We never talked about fungal, we never talked about brain abscesses, we never talked about pyogenic, amoebic, toxoplasmosis. So this is a huge list. And the differential diagnosis, as we all know, are varied. It all depends upon the circumstances, the age on onset, the kind of lesions, underlying HIV status or immunosuppressed state, patient is on chemotherapy. The differential diagnosis keep on changing. But in today's practice, most of us or maybe more than 95%, the tug of war is always between NCC and tuberculoma. So why I brought it and why I requested the chair that I want to show it, that once you are in the institute, this is a landmark paper from PGI where they showed these complex lesions which were taken for granted as nothing but tuberculosis are now proven beyond doubt that it is nothing but neurocysticercosis because of its manifestation in the form of ring enhancing lesions. So look at it. This is a very magnified view of one of the cases where you can see a tinea like structure within the MRI, but this is microscopic. So, this is the beauty of when the radiologist sits on the behind the screen and can produce wonders. So you can actually demonstrate in couple of patients uh, what we just called a scolex. You can see a very small microscopic tinea which is evolving. So all these are basically, there is a mother cyst and there is a daughter cyst which is you know uh, coming out of it. It is very naive, it has got a very fragile wall. That is why it appears as diffusion bright. So I told you, mind, everything is important. So diffusion bright, ring enhancing, lobulated, with a mother cyst which will have a very well defined wall, and a daughter cyst which will have seepage of you know contrast. I told you about the seepage of contrast, mind you, and that is what I wanted to emphasize, that this seepage of contrast which you saw even in this also in the top, this seepage of contrast around the daughter cyst is because it is still juvenile. So just a take home message or a summary of this eye opener was that the intact scolex that resembles remarkably like the head of intestinal tinea, but it is microscopic and can only be seen on very beautiful images, which the radiologist can do only on academic basis. It is not something which, as Dr. Garg said, it is not our cup of tea, but it is just to show, it is just an eye opener that how this tinea behaves inside the brain also. So single ring enhancing cystic lesion, everybody will jump to the diagnosis of NCC. But when it is complex NCC, still consider it and look at the other features of contrast enhancement, of diffusion bright images, which are there because there is intense inflammation which leads to diffusion restriction. So the complex lesions are conglomeration of multiple communicating cysts with single parent cyst. There will be a mother cyst, and from there will be multiple daughter cysts. It can be one, it can be two, and it can take the shape of a large tumorous lesion like I showed in the one which was proven on biopsy because the diagnosis was not clear. The patient was worsening despite being on ATT, right? And the parent cysts contain a solitary, variably degenerated scolex, which I showed you, had thicker wall and associated chronic inflammation with a thick wall. And the remaining cysts contain no scolex, poorly organized wall, turbid contents, florid perilesional edema with leakage of contrast. And that explains the diffusion restriction in inflamed tortoises. Now coming to the main challenging cases. So this is a young female who presented with 1 month history of fever, headache, vomitings, and presented with altered sensorium in our emergency. And this is the baseline MRI at the time of presentation. This was 2nd November 2023, right? And so the CSF was done, which was showing lymphocytic pleocytosis. The cell count was almost 230 with 95% dominant lymphocytes. The proteins were raised, 225. The sugars were low, 30. And the gene expert fortunately was positive, but the RIF resistance could not be determined. So we were very comfortable. We made the diagnosis of tuberculosis and we started the patient on ATT with steroids. But 2 months later, almost 2.5 months later, after starting ATT and while still on steroids, this patient deteriorates. Progressively worsening headache, vomiting, vision loss, progressively worsening vision loss, diplopia, and walking difficulty. That is the time we evaluated her again, and this is the MRI of this patient after 2.5 months. Sir, so how will we go? This is the MRI on 18th. That was the baseline MRI which we saw which was just showing mild, if we can appreciate, there is a mild prominence of the lateral ventricles with some oozing, and there is diffuse meningeal enhancement. And the CSF is suggestive, and we could get the gene expert report, which is positive. So there is no doubt about whether it is cryptococcosis or any other infection. It was tuberculosis. But the problem is now she has worsened. And this is the MRI. So after 2 months, despite on ATT and steroids, what will be our possibilities? Garg sir, how will we go about it? नहीं यहीं से बताया सर अभी. So with this type of worsening after 2 months, what will we think of, all of us? Okay, maybe I ask the audience. We will think of one is multi-drug resistance tuberculosis. That sounds important cause. The other important remains is
before resistant TBM, I will consider as a paradoxical reaction.
As a part of
paradoxical reaction.
Yeah, paradoxical response. So the other possibility is the paradoxical response, because now the patient's immunity is improving and this patient showed a robust immune response, and that is why this patient is having this kind of lesion. So that is one important. The third is that either we are dealing with some superadded infection or we are missing the diagnosis. So they always remain in our. So we did a CSF again in this patient, and again we could find gene expert was positive, but this time we could demonstrate that the rift resistance was not there, and the CSF was again suggestive of tuberculosis. So how to go about it now, sir? The patient who was diagnosed as TBM was on ATT and steroids, the standard therapy which we give, and this patient worsens. And now what will be the approach? Anybody from the audience would like to answer that? What will be their approach? How will we manage this patient now? She is already on ATT. HIV is negative. Can we have a mic? We'll just quickly, and then I'll show. We don't have any mics for the audience, please.
If the case as was supposedly taken as TBM, and if that is not improving, first, as sir said, it should be taken as paradoxical response. Secondly, we can take it as multi-drug resistant tuberculosis. We can also consider other infections, chronic infections like fungal infection, HIV, as some of our friends said from the back. And also we should consider metastasis and some neoplastic lesions. So these would be the differentials I would be
So
keeping.
that is how we always think, and that is why we admit and we do a complete workup again in these patients, one to prove the diagnosis. But in this case, again, the gene expert was positive, references was not there. So we planned some intervention. We'll discuss about it because it is out of text. It is just an experimental drug. We'll discuss about it later. And this is the beauty. So this patient came walking in last OPD on Thursday with this MRI, which was done on 12th of August, last almost 10 days back. So at times, so we will discuss about it. This is the beauty that once you diagnose and work up the patient properly and intervene, the results can be gratifying. So I'll show you another case of worsening. This is a 20-year male with low-grade fever of 1 month duration, holocranial headaches, feature suggestive of chronic meningitis. He was lethargic but oriented. Bilateral 6 nerve was there. Rest the cranial nerves were normal. And the CSF again was classical of tuberculous meningitis, and we could prove it. The CSF gene expert was positive, but then this case they couldn't because of the small quantity or whatever reason. They said the rift resistance is indeterminate. All other investigations were normal. So the patient, this was the MRI at the baseline. There is diffuse meningeal enhancement with mild hydrocephalus, and based on history, CSF, and confirmation of the diagnosis, we started the patient on ATT, 4 drugs ATT with steroids. But within 1 month, this patient again worsens, worsening of headaches, deterioration of sensorium, and he is readmitted. Now, this is the picture again. I won't say similar, but quite similar. So, sir, what to do next? Another case of worsening. again, the possibilities remain the same, like sir, you had already enumerated, whether it is a paradoxical response, whether it is MDR tuberculosis, whether we are missing the diagnosis, there is a superadded fungal infection, or this is only a fungal infection, but the patient deteriorated, and this is the MRI. Classically, this is a book picture of what TBM we used to see and discuss. It's a classical spider web appearance. But in this case now, we again, did all the workup, and again, gene expert TB came out to be positive, but this time it is gene expert is showing that there is a RIF resistance. And our microbiologist who is doing experimentally the whole genome sequencing of the tuberculosis bacillus, she said that there is a rifampicin and INH resistance. So now comes, this is the case of multi-drug resistance tuberculous meningitis with lots of tuberculomas, which we saw in this case. And of course, he was started on MDR treatment regime. Now I'll request Professor Garg, to just enlighten us on how exactly, how we can manage. All these guidelines are all from pulmonary tuberculosis, but he has a lot of experience and reviewed a lot of articles. So how we manage this?
Thank you, Manish. I will start from there where you have left, and I will make audience familiar with what is MDR tuberculosis and what is MDR tuberculous meningitis. This MDR tuberculosis just mean if Mycobacterium tuberculosis stop responding to common effective anti-tuberculosis drugs, then it is a state of this drug-resistant tuberculosis. There are three dominant type of drug-resistant tuberculosis. One is mono-resistant tuberculosis, and mono-resistant tuberculosis can be with any of the anti-tuberculosis drug, but dominantly, which is clinically relevant is mono-resistant tuberculosis against isoniazid, INH. Multi-drug resistant tuberculosis, it is considered when this organism, this drug organism is resistant to INH and rifampicin both. And the most dreaded variety is extensively drug resistant, that is MDR plus other additional drugs like fluoroquinolines and other injectable drugs. If mycobacteria is resistant to that, that is known as extensively resistant tuberculosis. As far as this proportion of resistant tuberculous meningitis is concerned, have you seen any case of drug-resistant tuberculous meningitis? Any resident have seen, have any experience? How did you find that person raised the hand? How did you find the drug-resistant tuberculous meningitis? What was positive in gene expert?
So, in gene expert,
What was positive? What did you find in gene expert?
so rifampicin resistance was detected. So then we sent for line probe assay.
In gene expert detect only in rifampicin resistant, but it is considered as MDR. MDR means INH plus rifampicin. INH rifampicin, if rifampicin resistance is present, this INH, it is also considered a surrogate marker for INH resistant. Rifampicin resistant in gene expert is equivalent to MDR. What is the mechanism of this? Mechanism of this drug resistance against Mycobacterium tuberculosis is genetically determined. There are 9 genes which are linked to resistance to first line anti-tuberculosis drugs, and the line probe assays, the assays which are available to identify these drug resistance utilizes these mutations in these genes. There are 9 or 10 genes which confer resistance to antituberculous drugs, and gene probe assay, this line probe assay identifies mutation in one of these genes. How do you clinically identify this drug resistant tuberculous meningitis versus drug susceptible tuberculous meningitis? Virtually, as far as clinical features are concerned, there is no difference. Both imaging as well as this clinical features of both susceptible and drug resistant TBM remains the same. Only you can suspect, and this rule for suspicion, frequent treatment, frequent relapses, patient leaving the poor compliance, all these things, they make patients susceptible for drug resistant pulmonary tuberculosis as well as drug resistant TBM. But the diagnosis is made on either phenotypically by conventional method of culture or genotypically. The most common test is gene expert. I have told the presence of rifampicin resistance indicates also INH resistance as well. For other drugs, there is a test known as line probe assays. Line probe assays utilizes the mutation in the genes which I have just listed. The treatment, there is no information available specifically for drug-resistant tuberculous meningitis. Whatever is being done, we extrapolate from that information from that of pulmonary tuberculosis. So, as far as National Tuberculosis Elimination Control Program, elimination program of Government of India, there are 3 groups of drug, Group A, Group B and Group C. We have to utilize these drugs from these groups to make a regime specifically for pulmonary tuberculosis and same regime for drug-resistant tuberculous meningitis. There are various kinds of regime, shorter regime and longer regimens. Shorter regimes cannot be utilized for drug-resistant TBM because shorter regimens are utilized only for limited tuberculosis, limited pulmonary tuberculosis. Longer regimens requires at least 20 to 20 months of treatment, out of which 6 months is intensive phase, and in intensive phase at least we give 6 drugs or 5 drugs and it is continued for 22 months. So for TBM, how to choose a drug? For that we should know the drugs against which microorganism is not resistant and that drug has CSF penetration, adequate CSF penetration. I am giving the list. Most of the class group 1 drugs readily cross the CSF, and all these 3 drugs should be utilized for treatment of drug-resistant TBM. Earlier we suggested pyrazinamide, very excellent CSF penetration, linezolid, levofloxacin, ethionamide. Only kanamycin has a limited CSF penetration. Our government program requires this beta-choline to be added into the regime. This beta-choline has been found to cross CSF quite well. So now we can make a new regime adding beta-choline. Now all 5 drugs, pyrazinamide, linezolid, levofloxacin, ethionamide, beta-choline, all have excellent CSF penetration, and all these 5 drugs can be used for the treatment of drug-resistant TBM. But unfortunately, we don't have any data. We don't have any data to know whether this regime or any other regime can be really effective or not. This is our presumptive regime which can be used because of their better CSF penetration profile. The shorter regime, as I've told, that shorter regimes requires to be treated only for 6 to 9 months. But this regime, I wish such type of regime could be available for tuberculous meningitis patient. But unfortunately, this regime is only this can be used only for limited tuberculosis. Thank you very much.
Thank you, sir. But there is a lot to be done even for treating normal tuberculous meningitis also, Unfortunately, because of lack of time, 9 months regime is not suitable for most of our patients, but that's what the government policy says. And most of us sitting here treat them beyond 1 year and at times go up to 1.5 years also if the disease is not improving. So coming back to the previous case which we discussed, that this is the baseline and this was the outcome and this was the in between worsening of this patient, the same patient which I talked about, but there was no MDR. We took a lot of CSF, tried to prove that it is not fungal, it is not any other diagnosis, and it is only tuberculosis which is responsive to rifampicin and INH. And what we did was we added thalidomide in this patient as an immunomodulator. It's an off-label drug, still not commonly prescribed, but this is something which we have been using in PJ for last 15 years. And I won't say every patient respond, but in good two-thirds of patients there had been good recovery in myelitis, good recovery in vision loss, good recovery in size of tuberculoma. So there is an endless story of that successes like this patient. Again, a paradoxical response after taking ATT and on steroids, worsening, and this is what we got after starting thalidomide. Another non-responsive tuberculoma, 3 months of thalidomide, it is looking quite quiescent. Another tuberculoma presenting as optochiasmatic retinitis, bilateral vision loss, not responding to conventional therapy, given thalidomide, responds very well. So this is what we say, that it is a paradoxical response, an exaggerated host immune response, and iris, which is probably because of inflammatory mediators like TNF or more, and they contribute to the host immunity in tuberculosis. And it is because of the overproduction that there is, this kind of extensive exudate. So it's more of an immune mediated syndrome rather than a bug which is causing this worsening. So that is why we started using it. We tried to titrate on the dose part. We usually use it in the dose of 2 to 3 milligram per kg. Body weight somewhere around 100 to 150. It is a costly drug. We try to provide them ourselves if they cannot afford. And there are multiple mechanisms in the literature that it suppresses TNF, it increases interferon gamma, it stimulates CD4, it reduces IL-12 and increases IL-2. So these are the various theories or mechanisms proposed, but TNF remains an important cornerstone of immune mediated paradoxical response, and it reasonably suppresses without producing any immunosuppression. That's the most important part. Of late there are papers on infliximab also, again experimental drug, but is used in desperate conditions. And if you see the literature, people have used cyclophosphamide, cycloserine and whatnot to reduce the inflammatory response in these patients who are not MDR. And so I'll cut short my presentation and just say that it can be tried in complicated situations like iris, which I showed you, increasing tuberculomas, not responding, paradoxical response, progressive hydrocephalus, optochiasmatic arachnoiditis, myelitis, and it offers the protective immunity, that is what the word we use, to the host. And second line is not just recommended just like that the patient is worsening. So let us start with all the toxic drugs. Mind you, as Dr. Garg has said, the CSF penetration is low and the efficacy is very, very poor. So we have to be very judicious in using second line just as a knee-jerk reaction, and it shows a promising effect like in our series. And in certain cases, one can always try it, or they can reach out to us. We can help in managing such conditions. So because of short of time, we leave this here. Maybe if we have time, we will do it during discussion. I invite Dr. Vikas for the next very interesting case and with a good take-home message.
Thank you, sir. So, very good evening to all, and I'll be briefly discussing a short case, and this is a case which I had seen few years back, and this is a 38-year-old female who presented with headache, fever, which was severe in intensity, which was there for last 2 months, along with occasional vomiting. In the last 3 weeks, when she presented, she had 3 episodes of generalized tonic-clonic seizures also. Along with that, she had a history of HIV positive also. She was diagnosed in 2003, and the baseline CD4 in 2003 was 60. The initial regime was zidovudine, lamivudine, and nevirapine. In August 2020, she probably had a failure, and she was shifted to tenofovir, emtricitabine, efavirenz. Probably that was not a great choice at that point. Again in January 2021, when she presented 2 months before presentation to us, her CD4 was 26 and HIV viral load was 1,60,000 copies per ml. So she was on a failing regime when she had presented to us. So just to summarize the case, this is a 38-year-old female with advanced HIV, has clinical, virological, and immunological failure with subacute onset, slowly progressive focal CNS syndrome, and has features of chronic meningitis. So this is the imaging. We did an MRI at that point, and the MRI showed a irregular shaped alter intensity lesion involving the left parietal lobe post central gyrus, and this was associated with surrounding edema. Now, what are the differentials here we are thinking of? So, any thoughts from the panelists?
Possibility of tuberculoma. The other alternative could be whether it is for PML is one other possibility, being a retroviral positive disorder. So the patient may have other differential diagnoses. Toxoplasma is another question. So usually the four things which we need to differentiate are tuberculoma, lymphoma, then toxoplasma and PML. That these four are very important to differentiate among in a HIV retroviral positive patient.
Yeah, so absolutely, sir. And this is what exactly we thought, tuberculoma with an abscess formation. We also thought of CNS toxoplasmosis. We thought of CNS lymphoma and some atypical infections like nocardia, which are also common in this subset of patients. And since this was a patient who was an advanced HIV, we also thought of cryptococcosis. Although cryptococcus usually predominantly presents with meningitis, but in advanced HIV you can have cryptococcal abscesses also. In that, the etiological organism is slightly different. Usually with meningitis it is Cryptococcus neoformans, but with abscess formation it is Cryptococcus gattii. So we did the usual workup. We did the CT chest and abdomen, which showed few mediastinal subcentimetric nodes. There was no lung parenchymal lesions. VDRL was negative. Serum cryptococcal antigen was negative. Galactomannan and beta-D-glucan, both the fungal markers were negative. We also did the CSF analysis. TLC was 18. Almost all of them were lymphocytes. Glucose was 58 and the serum glucose was 89. Protein was mildly elevated, 109. Gene expert on the CSF was negative, and also India and cryptococcal antigen, gram stains, and aerobic culture were also negative. So at this point, we thought probably this is a case of tuberculous meningitis with a tuberculoma, and the patient was started on weight-based ATT along with dexamethasone to be tapered over every weekly. So, but things didn't go as planned. After 6 weeks, she had no major clinical improvement. Headache worsened with the steroid taper, had episodes of seizures in between, and there was no weight gain. Now she comes back to us, and this is the repeat MRI we did, and this showed that the left parietal lobe post-central gyrus lesion with perilesional edema has actually increased in size, and when this was compared to the previous scan. So, what are the possibilities now? Anyone from the audience would like to give some opinion on this?
Dr. Deshwal, I always teach my students that any ring enhancing lesion in HIV patient is toxoplasmosis unless proved otherwise.
Very important that you need to keep this in mind, especially in the retroviral positive patient.
Yeah.
Don't say that it is all tuberculosis. You have to keep in the differential diagnosis toxoplasmosis.
Yeah. So we also thought on the similar lines, and since this patient also had there were seizures and there was midline shift, and so this patient was taken for a frontal decompressive craniectomy, and the biopsy was done, and the biopsy showed many bradysites, cyst forms of toxoplasmosis. So a diagnosis of CNS toxoplasma was confirmed, and this patient was started on high dose trimethoprim sulfamethoxazole for 6 weeks, and this was followed by a prophylaxis to be continued for another 6 months to 1 year until her CD4 reaches more than 100. And since she was on a failing ART regime, her ART regime was also modified, and it was changed to dolutegravir, emtricitabine, and tenofovir alafenamide at this point. Now I hand it over to Dr. Satish to take us through ring-enhancing lesions in HIV patients. Over to you, sir.
Thank you, Vikas. I think you have set the platform for the retroviral infection associated with the focal lesions. How do you approach this problem? That is not common, and everywhere it is not the same. That is what exactly I wanted to emphasize here, because it depends upon what is the strain of the retroviral virus which you have in your country. In our country, it is predominantly due to HIV-1C with a very, very rare recombinant strain. That is what exactly is important, and most of our early cases were drug naive, but we have now a lot of cases with the heart regime induced one. So our experience changes over the time, and we need to understand and find out what we are talking about. So our experience at NIMHANS, where I was working, and we had 1989 to 2012, a large series of 1,375 cases of retroviral infection, predominantly with opportunistic infection. This is only the slide regarding opportunistic infection. As you can see here, the most common being the TB, tuberculous meningitis, cryptococcosis, then toxoplasmosis, then came the granuloma. And that is what exactly is the problem. And we need to look at what are these granulomas. So it is very difficult. Just now we heard Vikas talking about a case which was suspected as tuberculosis treated with anti-TB treatment. But later on, we noticed that it turned out to be toxoplasma. So these are called focal brain lesions, or FBL, in HIV clade C seropositive individual. This is a study, we took it up, and we wanted to do it with a definitive proof. So we discussed about 4 possibilities whenever we are talking about focal brain lesions with retroviral infection. What are those? Toxoplasma, CNS lymphoma, PML, and tuberculoma. So you have the different parameters we need to look at clinically. As a clinician, we look at the duration, we look at the fever, number of lesions, enhancement. Is it enhancement is positive? Usually it is toxoplasma. CNS lymphoma, enhancement is possible. But PML, unless it is associated with iris, it is not enhancing. That is one of the pointers we must remember. PML is always non-enhancing, and tuberculoma enhances. Then the site of the lesion, where it is. If the site is in the basal ganglia or cerebellum or the brainstem, invariably it will be toxoplasma. The moment you see a lesion in retroviral in the basal ganglia region, you can most often say it is toxoplasma. In the CNS lymphoma, more often it is periventricular and subcortical. In PML, as you all know, it is white matter, and tuberculoma could be anywhere disseminated one. And usually about the CD4 counts gives a clue. And whether it is toxoplasma, very low, CNS lymphoma, very low, PML also low, but tuberculoma can occur even with 150 to 300 cells. And this is a classical case of tuberculoma with almost coming into an abscess formation in a retroviral infection. This was a case of again a tuberculoma, as you can see, and MRS might be helpful in something to say that it could be possibly tuberculoma, and you can see that these are lesions which are coalesced there and to suggest you of more likely to be tuberculoma. So how do you approach the problem? One of the approach to the focal brain lesions with retroviral infection is it contrast enhancing mass lesion in CT or MRI? You say yes, then it could be, and you say no. If it is no, there is no enhancement, we can straight away say that it is PML. On the other hand, if it is enhancing, then you might require one more step. That means it could be a SPECT scan which may help. If the SPECT scan is positive, it is more likely to be due to lymphoma. And if it is negative, then it could be a toxoplasma or it may be the other etiology. And for a toxoplasma, you may have another approach that you look at possibly serology. And if serology is positive, you can say that as toxoplasma encephalitis or toxoplasma serology is negative, then it could be tuberculoma or cryptococcoma or candidiasis, as he was mentioning in the differential diagnosis. Other conditions you have to think about it. For this, we did a study of our 25 patients with a focal brain lesion associated with retroviral infection, and we did a stereotaxic biopsy thanks to our neurosurgeons who were not hesitant to do the biopsy. And Dr. Anand, I think he was there in the morning here in neurosurgery. He was the one who was doing all our stereotaxic biopsy. And what was then we went back and looked at the sensitivity and specificity of various investigations. What was that? Toxoplasma serology sensitivity is about 61.9%, specificity is about 75% if it is there. CT brain 85%, 75%, MRI 85.7% sensitivity, specificity was 75%, SPECT scan mainly for lymphoma, it is useful. Then we did a stereotaxic biopsy. What happened? In biopsy, and we had 21, and autopsy was 4. All biopsies were conclusive. We were able to say what is the biopsy and what has yielded. No biopsy related complications could be seen. Even in a retroviral infection, people are hesitant to do the biopsy. Surgeons mainly, they may not help us at all. But you have to have surgeons like our neurosurgeons who were ready to take it up as a challenge and then did this, and we were able to give an answer for this. And specific diagnosis was possible in about 72% of the cases with stereotaxic biopsy, and that the correlation we did that. So there are some paradoxical reactions even in cases of retroviral positive focal lesions. So what are these? Paradoxical TB reactions are most common in HIV infected patients, particularly in those where we commence the antiretroviral drugs soon after starting the TB treatment. See, you must be very careful when you have a CD4 count less than 100 or less than 50. Never start on antiretroviral drug just because it is a retroviral positive. If you do so, immediately you will go into paradoxical reaction, and that is nothing but immune reconstituted inflammatory reaction or IRIS. And that occurs in a patient whenever you start on antiretroviral drugs if the CD4 count is less than 50. So what should you do? You have to treat specific with the drugs. What drugs do you treat? It is based on your diagnosis. If it is tuberculosis, tuberculoma, start on anti-TB treatment. If it is toxoplasma, give the toxoplasma treatment and then wait for a month and repeat the imaging. Then if it is a lymphoma, you give a specific treatment and then afterwards you can start with the infection group. After at least 2 weeks of therapy, you start on antiretroviral drugs. Otherwise, you land up with TB iris as we can see here. What is the medical treatment? I think you have already heard about this from Dr. Garg, who has mentioned everything about it. So what I will say is corticosteroid therapy of maybe particular value when there is a significant perilesional edema and in cases where there is a paradoxical enlargement despite optimal TB therapy. That is what is important. And if it is a TB abscess and they are unresponsive to standard TB therapy with corticosteroid, as Modi has mentioned, Manish has mentioned to you, adjuvant thalidomide therapy, 3 to 5 milligram per kg per day, has shown to be beneficial in patients who develop enlarging TB abscess. That is what is important. We have forgotten about thalidomide. Now we have to bring it back, and especially in those TB abscesses which are not responsive to the treatment. And other immunomodulatory agents may be beneficial in steroid-resistant paradoxical TB reaction, and that could be TNF-alpha inhibitor like infliximab or interferon gamma. So, one of the important thing when you want to discuss about the retroviral infection and tuberculoma, the most important is rifampin can alter the levels and bioavailability of the ART drugs through that CP450 pathway. So if the patient is on protease inhibitor, then replace the rifampicin by rifabutin. I have used rifabutin and it is available in the Indian market. And as the rifampicin reduces the level of these protease inhibitors and the nevirapine also. So this is one need to remember. And the most important thing is always CDC recommends the use of efavirenz based regime whenever you are thinking in terms of the drug for the retroviral with TB. Then steroids may be used except in life-threatening opportunistic infection. We are saying that steroids could not be used in retroviral. It can be used if it is a very life-threatening infections like cryptococcal meningitis or cerebral toxoplasmosis. And then I think it is going faster. I don't know why. Yeah, delaying the ART initiation, I have already talked about paradoxical reaction. Then the other important is the treatment of the tuberculous meningitis related rifampicin resistant or a multi-drug resistant strain is best guided by drug susceptibility test. And that is what you have to look for. And the other drugs which penetrate, I think Garg has mentioned very clearly all the drugs what should be used. What is important is has he clearly analyzed pyrazinamide plus 4 core second line 4 core TB medicines, one from the group A, one from the group B, and at least 2 from the group C. And that is what he has listed out. I don't want to elaborate it further, and that's how you have to choose in these patients. Then what is the duration of the TB treatment and what happens in practice? We have all seen, I'm sure if it is floor is open to the question, everybody will raise the hand saying that even after 24 months of therapy, tuberculomas are there in the picture in MRI. Is it so? Yes, it is even 22% to 46% of cases. You will see those lesions. These lesions are there even in the imaging when you look at it. What is important is how long do we treat? Do we treat for 2 years? Do we treat for 3 years? But most of the recommended regime is only 6 to 12 months. So what will I do? I usually give it for 24 months. Whether it is 24 months is enough, some people say you will continue that. Do you have to have some guideline? I'm sure, unfortunately, there is no guideline for those conditions and it has to be on individual basis and you have to use your logical experience for that. The larger lesions more than 2.5 centimeters are significantly likely to persist longer. That is one clue. If you see a larger lesion, it is more likely to persist. I think Modi was very lucky in his case when he used thalidomide and disappeared everything. I was really amazed to see that picture very nicely disappeared with thalidomide. I wish it happens to all the other cases also. But invariably, what happens is these are the cases where it persists for a longer and you need to continue the treatment. There are a lot of benefits for ARV therapy. I don't think I will need to go into that. And we have, in this country, everything is available. All ART regime is available. And these are all acting at the different level, whether it is a fusion drug or entry CCR5 drug or reverse transcriptase drug or viral protease level or integrase. All these drugs are available in Indian market. But you have to use it very judiciously when we are talking about CNS tuberculosis and CNS infections, and always think and keep in your mind about the paradoxical response or iris, and you should be careful in judiciously using these drugs. I think we were part of the management of intracranial tuberculosis mass lesion. How long should we treat for? This is the question I'm sure everybody will ask. I recommend this article, and as you can see, this is a different way of doing it. Version 3, peer review 3. And then it is going on. It goes on already peer review 4. And the people will add the comments on that. And there is a tuberculosis meningitis international research consortium. And in this consortium, all three of us were there, and our names are there in this consortium, and we are looking at it, but there is no final answer for how long do we treat for tuberculoma, whether it is 24 months or even longer. Thank you very much. I think since I have a flight to catch up, questions will be taken by Modi and Garg. Thank you very much.
We can take some questions from the audience. Yeah, please.
Response to treatment or prognosis wise, is there any difference? You can also.
I don't think there is any comparative study, but this spinal tuberculomas respond very well to anti-tuberculosis treatment, and most of them, if these patients do not require surgery, and usually these spinal tuberculomas are medical condition, and generally does not require surgery.
I'll just add on to what sir said. So, spinal tuberculomas, the management is pretty much the similar as the meningeal tuberculomas. The only difference is that when you have a spinal tuberculoma as a paradoxical worsening, the treatment is much difficult. They are much difficult to manage, and they are usually not that much responsive to steroids and thalidomide as compared to the CNS parenchymal tuberculomas. So that is the major difference, and the same goes with the this. Usually, the vasculitic infarcts, or when you have a vascular pathology because of the because of the TB, that also is not that much responsive to steroids and your other anti-inflammatory agents like thalidomide and even infliximab.
Dr. Modi, thalidomide is available in what dosage? Tablets, thalidomide.
What dose we are using?
3 to 5 milligram you said.
Actually,
it is divided dose, single
2 to
dose.
3 milligram.
2 to 3.
Yeah.
Tablet
so I
is.
had some slides on high dose. You know, there is only one trial in the international literature on high dose of thalidomide which failed. They used it in every patient of tuberculous meningitis, but they used the dose was 24 milligram per kg. Just imagine. So there was more side effects. So within 1 month, that was used in kids. So that group which is using in South Africa, there are only two groups, you know, who are actively involved in this thalidomide business. So they are now, you know, following our guidelines. So 2 to 3 milligram is what they are using. Normally 3 milligrams. It all depends upon how the patients are tolerating it. Normally we didn't see any side effects as of now. It had always been good effects, but it is, you know, still an individual, you know, perception. We tried to use lower drug also based on our hematologist's suggestion. We used for a few months 50 milligram also. They said 50 and 150 are the same in hematological malignancies, but it didn't prove worthy of it. So we are using 100 to 150 milligrams, and we use it aggressively for first 3 months, and then we reduce it after the radiology is done.
So you give in a divided dose or single dose?
Divided dosages.
And it's
the
available?
thalidomide thalics come in 50 milligram capsule and 100 also.
100 also.
So we use 50 BD or 50 and 100. That is how we are using it.
I want to add something that none of the TBM guideline explicitly recommend thalidomide to be used in management of tuberculosis meningitis. All this use of thalidomide remains a personal experiences and anecdotal reports.
It is only
randomized control study which was conducted on that was withdrawn, and that shows no benefit.
in fact, increased mortality for that
most
matter. That's why it was withdrawn prematurely.
Pardon?
Yeah.
I hardly use, I rather prefer high doses of corticosteroid rather than this thalidomide.
There is a recent paper from CMC Vellore on infliximab 30 cases worth reading, but we couldn't reproduce the same in our institute.
So, the paper which Dr. Manish is speaking about, the CMC paper, I was involved in that paper, and when I was working over there, and they had actually used TNF-alpha inhibitor infliximab in around 20 cases, and they published their experience recently. What they found was that they found very good response with TNF-alpha inhibitors used in paradoxical worsening, and they had given 3 doses of infliximab, 10 mg per kg at interval of 1 month. it seems quite a paradox kind of a situation that when you have a TNF alpha deficiency, you actually are susceptible to develop tuberculosis, and now you are giving a TNF alpha inhibitor to manage a paradoxical worsening. So this actually pathway is mediated by LTA4 hydrolase gene, in which if you have that gene, then you are a hyperinflammatory phenotype, and if you don't have that gene, then you are a hypoinflammatory phenotype. So this actually works in those only who have a hyperinflammatory phenotype. So that is what they did in around 20 cases, and they actually showed very good results with that. Now they are actually trying 5 mg per kg of infliximab, and that too, 2 doses. They are doing it as a prospective RCT, and they have started enrolling patients in that.
I would just like to read a statement from my paper in Central Nervous System Tuberculosis in the Journal of Neurological Sciences, 2001. And I had written that although anti-tuberculous therapy has been around for approximately 60 plus years, even today, the optimal composition, appropriate dosage, and duration of therapy has not been determined for the management of TBM. I am now out of practice.
Sir, things
But
remain the same.
I will leave it for the younger generation
Sir,
to move this and prove me wrong.
sir, things as on today
I
remains
would like you all to prove me wrong.
Sir,
We are listening to foreigners talking about TB treatment. I think it should be India which should be telling the world how to treat tubercle meningitis. I tried to have a task force. Manish knows that. And it just didn't take off. I wish somebody younger takes the whole thing on.
I agree, sir.
Here we are talking, but there's no action.
I fully endorse what you say, and things remain the same over last at least for 30, 40 years. Anti-tuberculosis last guideline, WHO guidelines, which came into force, which we also apply even today, was published in 2010.
Thank you, sir. Just to add the experience about the thalidomide, I have personally treated 2 patients. Young patient, one was fruit seller. He has multiple tuberculoma of 30 years age, fruit seller. And with treatment of about 6 months, he developed spinal erythrodermatitis and unable to walk and had retention of urine. MRI suggests contrast enhancement, and he took treatment for 9 months. Then, according to the TB regime or the national guideline, he could not procure the ATT from. Then it was continued, and I added after 6 months thalidomide, that is the 50 milligram capsule, and it was continued ATT plus thalidomide for 24 months. And fortunately, that fruit seller is doing his job. One young lady, she was also home done, and completed her family, developed multiple tuberculomas, again developed erythrodermatitis at 3-4 months, unable to walk, similar response to thalidomide. Just to share the experience.
Thank you, sir.
Hello. Yeah, can I also just make a comment? Instead of, it was very satisfying to see the effect of thalidomide washing off those lesions. But I think it's a practice of most of the neurologists that when we see such paradoxical lesions, we increase the dose of steroids. So 1.5 to 2 times the dose we have used in many patients, and many a times we have seen a satisfactory response. So should we try this first, or should we use thalidomide as a first-line drug when we are encountering such a situation?
I'll answer that. Same thing is our experience. We have been using even IV methylprednisolone also when the patient is losing vision. You are, helpless. We are doing a randomized trial of steroids with thalidomide and this paradoxical response. We are still, still recruiting patients, and we'll give you this answer proper. It's a randomized control trial. I am not aware what the patient is getting. Somebody is delivering the medicine, somebody is taking. We are just seeing whether the patient is improving or not. So this answer maybe give us 6 months more. But the point is, increase in steroids, giving methylprednisolones do work. But the question is, the patient was already on 2.5 months of steroids, 3 months of steroids, and he is worsening in front of your eyes. Look at it. So you really feel helpless. You tend to give, linezolid, levofloxacin, ethionamide, and whatnot, whatever you can offer to the patient to just get rid of this disease. I don't disagree with that approach also. But as Sir has said, it's so disgusting. We are following 1980s guidelines blindly from pulmonary tuberculosis without knowing how much drug is actually penetrating after 6 months of your treatment. We don't have the final answer. So steroid versus thalidomide, you will get a proper randomized control trial in maybe another 1 year in published literature.
Thank
Sir.
you, sir.
Sir, unfortunately, I cannot do that. But we have got, close to a footfall of 200 patients every year who have these complications, and I'm sure we'll be able to give very good results to you.
Thank you, sir, for that very informative talk. I just wanted to change the scene a bit and ask about tubercular arachnoiditis. So, what would be the plan of action, and what is your experience with the hyaluronidase?
So, when you talked about spinal tuberculomas, they are not very common. It's mainly the spinal arachnoiditis with intense mellitus, which actually wrecks the nervous system and produces a lot of complications. In that situation, as a desperate effort, as I told, again, an unlabeled and off-label use of methylprednisolone as a rescue therapy, and then we are using thalidomide, and again, it is close to 2/3 of patients. We are not, and then we use infliximab, and in fact, we are using infliximab upfront also. But still, some patients are responding. We have now 10 patients on inflixi, and more than 200 patients on thalidomide. So I won't say thalidomide is a wonder drug. We are still looking for, something which can help.
Can I answer?
Sir.
There are two, the patient who survives, there are two disabling complications. One is optochiasmatic arachnoiditis leading to blindness, and many of these patients are young females, and patient get improved with anti-tuberculosis treatment, but vision never returns. And that is one of the most unfortunate thing which happens in front of you and you cannot do anything. Number one. Number two, second complication, disabling complication is spinal arachnoiditis leading to disability in walking, paraparesis. And most of these patients are young children, especially males, and many times they are never able to walk, and we are not able to do.
Yeah, I'll just add on
incontinence as well.
But we have success stories to share, sir. That's why I would request you try thalidomide in a couple of these patients. A patient who is paraplegic, a patient who is blind, and he gets vision back, or he's walking and coming, walking to your clinic without a catheter, it's gratifying. So if nothing works, that's why I said, rule out MDR, use immunomodulation, and maybe we come with the infliximab guidelines soon. The big group is, trying upfront use of infliximab straight away in any patient. But I think it is not that logical. Infliximab first contraindication is rule out tuberculosis. So TBM, start infliximab upfront is not probably the right answer. It is only when your immune system is becoming too robust and it is wrecking the nervous system because of immune mutilation. That is the time to intervene.
Recently, Dr. Katrak reviewed whole of the literature related to TBM, and probably there is nothing to suggest that optochiasmatic arachnoiditis and spinal arachnoiditis can be treated effectively and with guarantee. There is nothing.
So just to add on to what Garg sir is saying, that the optochiasmal disease, if you give a good immunomodulation, pretty early into the illness, it is reversible. It can improve. But the spinal arachnoiditis is a very difficult problem. It will not improve. And similar thing, which the infliximab group, which the CMC guys had published their study, they also showed that the optochiasmal disease actually responded pretty well to
Unfortunately,
that.
Dr. Deshwal, reproducibility is very less.
Yeah.
In one patient, you can say the patient is improved, but this you cannot guarantee in your another patient.
Yes, so that's what I'm saying, sir, that there is something called as hyperinflammatory phenotype and hypoinflammatory phenotype. Some people would respond exuberantly to the similar problem, and those are the patients who actually benefited. There is a trial also, steroid trial, dexamethasone trial also on this, in which they have stratified the population based on that. So in the hyperinflammatory phenotype only, you will have a benefit with the immunomodulatory agents, is what I wanted
Dr.
to say.
Vikas, I think we have, now entered into a hot debate which will continue. Maybe we can spend the whole night on this. So I think because of the lack of time, we will have to wind up. A final word from the master of tuberculosis, Katrak sir.
No. I think your statement is a little paradoxical. Because spinal meningitis is a spread of tubercle meningitis down. Primary spinal meningitis is rather rare. It is usually secondary to tubercle meningitis in the nervous system. And there also, it is the opticochiasmal area, which is there's pooling of CSF. That is where you get the problems. Do you understand?
Yes, sir.
So I think you have opticochiasmal meningitis more common than spinal.
Absolutely.
As a complication. Yeah. So if the origin is resistant to treatment, the origin is responsive to treatment and the after effect or complication is resistant to treatment, doesn't make sense to me. I think they are both complications. They can be resistant either in the eyes or in the spine. But I think the younger generation must get off its back. I tried to do it, and I'm openly saying I failed miserably because, let me be very careful, wordings that a three-letter word beginning with E and ending with O comes in the way of collaborative studies. And people are afraid of publications. I'm sorry, I have to say this in public.
I agree, sir. I agree.
But I think we should keep our egos in the back burner and get along with this work for the benefit of patients of tuberculosis. Yes. Thank you.
Thank you, sir. Thank you. And with that, we'll close the session. Thank you. Sure.